Great. I'm so happy to be here to talk about something that really is near and dear to me, both proactive dentistry, which I will explain in a moment, and also the concept of what patients want, what dentists want. We don't think about that very often. We go into our offices and we just work, which is great. But what do our patients really want? I think we know that they want something that's safe, something that's quick, something that lasts for a long time, something that is reasonably priced, of course. And what do dentists need? Dentists need something that's predictable, I think proactive, and something that is profitable as well. So we need lots of different things. Some of these things coincide and some do not. So I'm going to be bringing up things that we can make possible for our patients and also make our lives a lot happier and simpler and more enjoyable. So what is proactive? Okay, what am I talking about with proactive dentistry? We always hear about minimally invasive, and minimally invasive to me means I'm not going to hurt the patient that much. I'm not going to cut up too much. I'm not going to invade too much. Minimal intervention means I can twiddle my thumbs a while and just wait till things happen. The concept of proactive means I'm going to know what's going on. I'm going to be predicting what's going on. I'm going to be aware of the details, and I'm going to proactively intervene when things need to be done. So together, as an umbrella of proactive dentistry, will give us the possibility to have a win-win situation to get patients what they want and dentists what they need. Several years ago, I put together a journal. By the way, I'm the December editor for a magazine called Oral Health. It's the largest magazine or journal of dentistry in Canada, most frequently read dental journal in Canada. And the concept was proactive intervention dentistry and the dawn of bioactivity. Now, I know that you've heard a bit about bioactivity over the years. It is very complicated for people to understand it because everybody has a different definition, depending on who you speak to, whether it's a company or a researcher. So I'm going to give you a very simple definition of what bioactivity is and make it a lot more easy to digest and easy to understand. And then you can go over to different manufacturers and say, well, this product, is it really bioactive? Because I was told that this is what bioactivity really entails. So you'll know a lot more as we go along. So dentistry obviously has been changing over the years, and today it's even more advanced than it is on the right part of the screen. You've got all sorts of different things that are available for our patients, including AI. So dentistry is always changing, and it's an exciting time to be a dentist and be in the dental field. The idea is the old days, we were thinking just to repair, just to sort of, work through different details to get, like, basically putting in a placeholder like an amalgam or something of that nature. Now we think more in terms of bioactivity and regeneration, mostly in the perio field. So I'll be going over things in the restorative and in the perio field and giving you a little taste of what there is in terms of bioactivity and proactive intervention. This is a little bit like it's biological dentistry. It's the connection between medicine and dentistry, and a little bit on the systemic world as well, because the mouth, believe it or not, is attached to the rest of the body. I don't know why it was ever detached and we became dentists only of the oral cavity and not of the rest of the body. Because things that we do impact the rest of the body. And we have to be aware and also make our patients aware because they want healthy bodies. And if we can help them achieve that, the wellness aspect, they'll be very, very happy with us. So what does it mean to bioactivate? Okay, so in the old days, we wanted a material that just had limited toxicity. It's not going to hurt them, hurt our patients. Then we wanted something that just would be bioinert, sit there, be a placeholder, stay there and sort of do nothing, but be there, structurally for our patients. And then we needed it to be biocompatible. You don't want it to hurt the patient's other tissues, Today, it's not just enough to be have limited toxicity, be bioinert, be biocompatible. We need things to be bioactive because they work with the tissues. So what exactly is the word bioactivity? What does it mean? If you go back to the dictionary, you can look it up. I'm not sure which dictionary I use, but one of the standard dictionaries. It means having an effect on or interaction with or response from living tissue. In terms of restorative materials, it started with things like glass ionomers in the 1970s. It's bio plus activity. So it's interacting, having an effect on or response from living tissues. So what are the mechanisms of bioactivity? This is really important to understand. And when you speak to a manufacturer or someone about bioactivity, you have to know these three concepts. So the first one is it can remineralize and strengthen tooth structure through fluoride release and the release of other minerals. That's one. And it can also, not all materials, all the second and third tier, which we have here, do also remineralize and strengthen tooth structure. But some also form an apatite-like material on the surface when immersed in bodily fluids. Not everything does that. And not all regenerate live tissue to promote vitality in the tooth. Some do that as well. But bioactive materials, the actual, let's say, the lowest tier of bioactive materials will remineralize and strengthen tooth structure through fluoride release and release of other minerals. So these are the ones that we need to work with when we're doing our bread and butter dentistry every day. We want things that will remineralize and strengthen the tooth structure through fluoride release and release of other minerals. So let's look at this table. The non-bioactive materials are like amalgams and composite resins. The ones that are bioactive, the first tier is the remineralizers. Those are glass ionomers, glass ionomer derivatives, and gyomers. And I'll be speaking a lot about gyomers because they seem to have the best of all worlds. They have the ability to be healthful and work as bioactive materials, but they're also stronger than glass ionomers, don't break down, are more aesthetic, and all those other aspects. So those are the ones that are bioactive, and those are the ones that can be used as aesthetic materials and good restorative materials. I'm not going to be talking about the deposition of hydroxyapatite for pulp regeneration. I usually do that in a longer lecture. This one is just a short 1-hour lecture. So I'm just going to be discussing the remineralization aspect of bioactivity. So we all know, I think we all know, but the fluoride reservoir, only micro quantities of fluoride are needed to have an impact on the and demineralization process occurring at the enamel surface. After you have a topical fluoride or you use a fluoride toothpaste, the calcium fluoride material precipitates throughout the mouth. And these precipitates are stored in the plaque and the enamel surface. And this precipitate is viewed as a fluoride reservoir. The reason this is important is because some bioactive materials like gyomers will actually be sort of a bank or a fluoride reservoir for when the fluoride is needed in other areas in the oral cavity. So our bioactive restorative materials, to just go back to it and recap, are glass ionomers, the gyomers, and also the tricalcium silicate cements like biodentin, but that's more of a regenerative kind of thing, which we're not going to be discussing tonight. So glass ionomers, we know, improve dentin hardness because they actually get fluoride and other minerals to come into the dentin. But as I mentioned before, they're not strong, they're not aesthetic, they break down easily, they're not long, there's no longevity to them. So something else had to be developed. And what was developed quite a few years ago, which is a materials I used I've been using for many, many years as my go-to material for general restorative dentistry. It's my go-to in all ways, is the gyomer material. It's called PRG, or pre-reacted glass ionomer. And the technology is revolutionary in terms of the fact that it takes a lot of the pros of glass ionomer and the pros of composites, and it hybridizes the two. So the disadvantages of poor aesthetics, the disadvantage of poor longevity and moisture sensitivity and a breakdown of the glass ionomers is now taken away through the composite aspect. So it's a combination of composite and glass ionomer. What is done, a little bit of, I always have a little bit of science, so you'll have to bear with me with a little bit of science because it's important to know the background, and then you can speak intelligently with the manufacturer when you want to know more about the material, and that is really key. So basically, you've got a multifunctional glass material which undergoes an acid reactive fluoride, a polyacid liquid reaction with the multifunctional glass. And then there's another glass ionomer reaction, and that creates what you see on the right side, which is a glass core in the center, a glass ionomer phase around it, and then a surface modified layer. So it's a hybridized idea of glass ionomer with all the positives of glass ionomer and also all the handling and physical properties of composite resin. The other advantages of the Giomer are, besides the fluoride release and recharge, is the anti-plaque effect, the fact that it remineralizes dentin, and also it buffers the acids in the mouth. Because it has a lot of other minerals in it, it's got the silica, aluminum, strontium, boron, sodium, and fluoride. So all of these aspects allow for the Giomer to give you the fluoride release and recharge, the anti-plaque effect, the dentin remineralization, and the acid buffer effect. So what do I mean by the anti-plaque effect? If you have a restoration that is with the Shofu Giomer, you're not going to have plaque develop on the restoration. With other restorative materials, you will have plaque develop over 24 hours. This was done in vitro, but it's also in vivo. I happen to have a couple of Giomer restorations in my mouth, and I know the ones that have that are Giomers do not develop plaque on the surface. So there's an anti-plaque effect. There's no mature plaque formation. And the other great thing about the Giomers is, as I mentioned before, they serve as a bank for fluoride. Whenever there's more fluoride in your mouth, they go into the Giomers and they're stored there for when they are needed. So when they're needed, when there's an acid attack or there's something where fluoride is needed in the oral cavity, especially around the restoration, that's when the Giomer will release the fluoride so that the fluoride can act to make the tooth more less susceptible to decay and stronger to withstand the acid attack. So as I mentioned, the go-to material in my practice is the beautiful Flow Plus. It is what I use for basic restorative dentistry. All my direct fillings are usually with Flow Plus. Sometimes I do use hybrids, but mostly the Flow Plus because I find it easy to use. You can sculpt it, you can put it in place. It flows beautifully. And it's so easy. Basically, I'm an artist with my Flow Plus and a scientist and a restorative dentist. So in terms of features and benefits of the Giomer Flow Plus, its physical properties rival hybrid materials. The handling is incredibly easy. As I said, you can flow it anywhere and it behaves itself. It's got a really nice aesthetic finish. As I mentioned before, we've got fluoride release and recharge, the anti-plaque effect. And so it's a proven Giomer technology, which has been around for over 20 years in terms of the technology. The Flow Plus has not been around that long, but the original Giomers, I believe, there have been studies. I know years ago they were 18 years old. or either 13 or 18, but anyways, it's been over 15 years that the Gymers have been on the market. And there are two viscosities to suit indications. There is the one that just sits in place as you place it, which is the non-flow, the 0, 0. And then there's the low flow, which has an ability to move around a lot more easily. And I'll just show you some examples in the next few slides. So physical properties, as I mentioned before, they rival the hybrids. And the 510K was predicated on Beautiful 2. So it acts just like a hybrid would, not in terms of the physical properties, as a load-bearing material with excellent compressive strength, flexural strength, elastic modulus, and wear resistance. Beautiful Plus as well is very opaque, which is really important. I know that in the past, I've used materials that were radiolucent. And then when I look at them when I go through the x-rays and I know I put a filling in there, where is it? And also, if you're showing it to your patients, I once had a lawyer in my office and I'd put a filling in there and I was showing him where the filling was. And he said, I don't see a filling. So I got a little nervous, but anyways, he's a friend, so it wasn't a problem. But it's really important that the flowables, which is rare that flowables are so radiopaque, but the flowable, Gymer flowable, Beautiful Flow Plus is definitely radiopaque. Now, one of the reasons people switch or enjoy materials is the handling, the handling properties. If you want to launch a product, the most important thing is the handling, because dentists don't want to change. So handling is very key. And one thing about the Gymer flowables, the Beautiful Flow Plus, is the handling. As I mentioned before, as you can see on the screen, you've got the one on the left is the OO, which just sits there, does not flow. It maintains its shape, the shape that comes out of the little tip. Now, it doesn't have to be, there aren't extra little ridges that come out. It just comes out and it doesn't keep flowing, which is really nice as well. It's got incredible, it stops flowing and it goes exactly where you want it to go. The other one on the right is the 0, 3, and that one will relax itself and go and flow into different areas a little bit more easily. So you can see that on the right, the OO maintains more of a diamond shape, and the low flow is rounder. So it's non-slumping, self-leveling, and not sticky. So it doesn't get pulled back when you touch it with an instrument. But I usually just use the tip of the syringe as well. So it levels and holds its shape with or without a matrix band. And with the other materials, you have to use an instrument or a burr to shape it. So you can see on the left, you've got the first one is the OO, which really means that conical shape. And the other one is the 0, 3, which again is used for different circumstances. And you'll start using one or the other more readily. I actually like to use the 0 more than I use the 0, 3, but other people use the 0, 3 more. It depends on, it's a preference. But definitely it's very, very, very different from the other flowables where you have to use an instrument or a burr to shape them. So the viscosity also allows the injection of the material for a buildup. So you can create your ridges more easily. If you want to be a sculptor in your dental, when you're creating the restoration. Every dentist is either a sculptor or a carver. On the right side, you can see somebody who'd be more likely to be a carver. Here you can use the more layering technique instead of creating your ridges. So, and then you go back and you carve it down with your burr. So dentists are usually sculptors or carvers, you know what you are, but you can use the Flow Plus as well in layering technique, or you can use the hybrid. So on the left, you can see the technique. First thing you would do is you would put the Beauty Bond and then a flowable underneath, the Flow Plus, and then you build up the ridges with the OO because they will stay a little bit more. It will not slump at all. The O3 will flow into the areas more easily, but the shape will not be maintained as easily. But you play around with it. You should probably try it on maybe some extracted teeth or some models and play around with it to see how easy it is to work with. Now, I had a patient come in who was an older gentleman. Now, older is very relative. The older I get, he seems younger all the time. But you can see on the left side, he wore down his teeth over many years. They weren't sensitive. They were functional. There was no reason to do anything in particular in terms of endo or anything like that. They were strong. He had good bone structure. So the easiest thing I could do was just use the flowable, and I used a lot of the OO here to build up those teeth to what you see on the right side. So each of those was treated. And if anything starts breaking down again, you can just etch it, bond it, and flow the material on again. So it's so easy to use and so forgiving. There's no issue in terms of having to work on the materials in any particular way. If he comes back to the same situation on the left, which he did not, it lasted several years. I have had to do some repairs, but nothing much because it's well maintained. He was very good about his oral hygiene, and it worked really well. And this is a long-term solution for somebody who didn't necessarily want to have crowns or whatever. And this was something that could be done very easily, quickly. So if we're talking about what patients want and what dentists need, patients want something that will be quick, reasonably priced, and something that is not going to cause any damage in any way. They want minimally invasive, which, as I mentioned, I don't like using the term minimally invasive. I like proactive intervention more, but we're intervening here in a proactive way at the stage where we can fix it easily and it can be repaired if it has to be done again. And for the dentist, what does the dentist need? Dentist needs something that's predictable, easy to use, and profitable, because you can charge a very good amount for this because it's taken you some time, but not too much time, and you're going to be well remunerated for the time spent. So it's what patients want, what dentists need, and it's the proactive approach to restorative dentistry. Now, this is something that I coined the term perimeter prep, and it's a great way in terms of profitability, minimally, as I said, minimally invasive, proactive intervention, and something that's profitable, predictable, profitable, and something that the patients will really enjoy. So basically, this is a patient who came in with a restoration that was failing a bit at the edges. And what was done here is I used the fissurotomy burr by SS White, took out the staining at the edges, and if there was any recurrent decay, just a little bit, there was a bit, washed and dried it, bonded it with Beauty Bond, dried and then cured the bonding. Then I went in with the Flow Plus. Here I used the OO. Some people might want to use the O3 because it does flow a little bit more. And it was so easy to create this in minimal time, so it could be very profitable. And it's just like doing a class one. The patient doesn't have to be anesthetized because with a fissurotomy burr, especially, it's exactly at the dentin, and it's a nice little conical shape, feather edge, and it doesn't cause any sensitivity at all. And so here we have the initial situation, which was slightly broken down, stained, possible redecay, but not much. And then the situation on the right is a easy, quick, predictable, and profitable way of doing dentistry in a very proactive approach. So this is the conservative repair of the worn restoration, and this is the perimeter prep. And this you can charge as a class one restoration because you are doing a class one. The rest of the restorative was intact. So why not just remove what has to be removed? It's proactive intervention when the patient needs it. It's a win-win for the patient and the dentist. And what about just repairing if there's one area on a class two that needs to be repaired? You can turn it into a class one and only take out the area that was stained and redecayed, and then flow in your OO or your O3, a Beautifil Flow Plus. And there you have the before and the after. The patient goes home with a restoration that will have great longevity and be something that they can work with easily, and it didn't take you very long. You didn't have to anesthetize, and you could do this very quickly, and you are remunerated again quite well. So you can also do, instead of removing a marginal ridge, which is definitely not the best way of servicing a tooth, you can go through in the posteriors as if it's a class three. On the buccal surface, it's easy to do. And you just use a matrix on the side, and you can do a lot of class threes with this flowable material. So you turn a class two into a class three, and the patient has a marginal ridge that's still intact, and you can do this quickly and easily. So that's the before, and here's the after. Why not think outside the box? Because you can be a sculptor, you can be an artist, you can use this material, and you're using something that's bioactive. So the margins are helping the patient in terms of the fact that it will not be easily redecayed. So it's a very easy, quick, and bioactive and proactive way of doing restorative dentistry. So here is a conservative preparation again, class twos, if they're not very large. A regular class two restoration, if it's very large, probably I would go with a hybrid with a Beautifil 2 material, but which also has the gymer properties. But when it's a small restoration, you can place in very easily the flowable material, and you'll have a great class two restorative material that will be serve the patient for very many years. So just to recap, in terms of bioactivity, we know that a bioactive material can remineralize and strengthen the tooth structure through fluoride release and the release of other minerals. That's the primary function of a bioactive material that interacts with live tissue. Some also form an appetite-like material on the surface when immersed in bodily fluids, and some regenerate live tissues to promote vitality in the tooth. The one that we use for everyday bread and butter dentistry is the one that remineralizes and strengthens tooth structure through fluoride release and the release of other minerals. And that is the material that works like a composite and like a glass ionomer. And in my practice, it's the gymer from a Beautifil, from Shofu, which is the Beautifil Flow Plus. and the beautiful 2 as well, when I need a hybrid. All right, so now I'm going to be discussing a little bit of perio, because as proactive win-win dentistry, we need to take care of the patient, the entire patient. And the patient now is asking for things related, they know about the oral systemic link, and I'm going to go over that a little bit. But first, we'll go a little bit of science on what's going on in the periodontal pocket. What is periodontal disease? Okay, so what are the periodontal disease therapeutic strategies? We need to reduce bacteria, of course. We have to get rid of risk factors, and we can use some enzymes if we need. And all of that will give us the best chance for clinical improvement. Now you can see on the left side, I have something in large, in yellow large font, and that's lasers. And lasers, to me, are the most amazing thing in terms of periodontal therapeutic strategies. And we'll go over that in just a moment. But we're going to go through a little bit of the science behind periodontal disease before we go to lasers, because then it'll all make sense towards as I bring up the science and how we work on getting the best therapeutic approach for our patients. So let's think back of what periodontal inflammation is. I'm going to simplify it for you. Now, inflammation is not a bad thing. We always think of inflammation as being, oh, the evil inflammation. Inflammation is what helps us heal, but it has to be stopped at the right time. So periodontal disease is a biofilm-associated inflammatory disease, like a lot of other systemic diseases in the body. It's all about the bacteria, but not only. It's sort of about the bacteria. The bacteria start a cascade, and the cascade has to be stopped, and that's the healthy, beneficial inflammatory response. So I'm going to show you a few slides on what this is. As I mentioned before, sometimes I do a longer lecture, and the longer lecture has a little bit of biochemistry, which you're lucky you're not getting. So what's in the acute response in what we see in the periodontal tissues? We have vascular dilation, increased permeability of capillaries, and increased blood flow. That's why we see blood in inflamed gums. At the cellular level, this is what's important, because I'm going to bring this up in the next few slides. We have the crevicular fluid. This is something at the cellular level, so we can't see it. It contains neutrophils. You'll be hearing a lot about neutrophils, also macrophages. And the neutrophils are the first responders in inflammation. These inflammatory cells secrete cytokines, which are the messenger cells that regulate the inflammatory response. So here we have plaque, you've got the bacteria, and you've got these neutrophils, and they are releasing the cytokines that do the regulatory. But the neutrophils are the important. They're the first responders, and they're around through the whole process. So the active resolution of the acute response, we need to have in the periodontal tissues, we have the bacteria is removed, and the crevicular fluid now has fewer weakened neutrophils, macrophages, and remnants of bacteria. So you can see here, the bacteria has been removed. You still have the neutrophils. There are fewer neutrophils here, but they can be measured. And I'm going to be telling you a little bit about the neutrophils being measured and how that's an indication of how much inflammation the patient has. So in the healthy, beneficial inflammatory response, you want to return the patient to health. So this is what you're going to see, not obviously in the cellular level, but you're going to see lack of redness, lack of bleeding, and this is a healthy situation. The problem is a lot of our patients are in this chronic maladaptive inflammatory stage. And here we have lots of plaque, lots and lots of neutrophils, and the neutrophils keep releasing these cytokines, and the cytokines end up releasing other factors. They are the messenger cells. The neutrophils release messenger cells that regulate the inflammation. But now inflammation has gone haywire. We don't want that to be. We want inflammation to stop. And it keeps going and going and going. You're going to have the periodontal ligament breaking down, and more neutrophils break down, the osteoclasts are breaking down bone, and it's a big mess. So this is where the systemic link starts appearing. There are certain pathways of action. Periodontal disease is a significant contributor to the total inflammatory burden on the body, and it can adversely affect systemic health. This is very important. So when we're taking care of our patients, they want us to be their healthcare provider. Their oral cavity impacts on their body. So what they want is for us to help them regulate that and get rid of their issues with systemic health. We have to keep the oral cavity healthy. So this will make sure that the oral disease does not contribute to systemic disease. Now, this is an important visual. Basically, you can see that the periodontal pocket contributes by several methods. Bacteria can go to other parts of the body. Cytokines in the periodontal pocket will work on organ systems in the body, and also the periodontal ligament, periodontal area itself is causing inflammation, and that inflammation is going throughout the body. So I will itemize those factors here. The ulcerations of the pocket epithelium can produce a risk for distant site infections and transient bacteremia. Bacterial diffusion releases bioactive molecules into the systemic circulation, and that can trigger a remote inflammatory response. So it starts in one area, and the bacteria from the pocket can go into the other areas and start a new inflammatory response. The cytokines from the pocket the cytokines from the pocket itself, as well as the other areas where the bacteria have mobilized and gone to other areas in the body, they release cytokines. And those cytokines can act systemically to affect organ systems. They can affect arteries and organs, and they can induce the liver to produce something called CRP, which is C-reactive protein, and that can cause problems like cardiovascular disease and stroke. So the cytokines can go to other areas. The bioactive molecules like bacteria can go to other areas, which can cause other areas to create their own inflammatory response. And the cytokines themselves can act on the organ systems, and they can cause C-reactive protein to form, and that can affect the liver and the cardiovascular system. So there is definitely a connection between oral and systemic. And you can see here, it can affect the eyes, the blood vessels, the lungs, the digestive system, the skin, the brain and spinal cord, and all these other areas. Everything is affected by the inflammation in the oral cavity. This is something I picked up a few years ago. Dr. Charles Mayo of the Mayo Clinic fame in 1914 wrote an article called Mouth Infection as a Source of Systemic Disease. He's also known to have said that the next movement in preventive medicine must come from the members of the dental profession. This was over 100 years ago, where he said that the next movement in preventive medicine comes from the dental profession. So we are in charge of our patients' systemic health as well. So how do we break the link between bacteria and the inflammatory pathways? First, you have to measure what's going on. How do we know how much inflammation is going on in the body? When you go to the physician, they measure neutrophils in blood and urine. So neutrophils, as I mentioned, are the first responders. We have to measure them as well. Oral neutrophils are the first responders in oral inflammation, and they're definitely quantifiable. There is a new oral neutrophil test that measures the enzyme changes on a special reagent strip. Basically, it's rinse and spit, dip the tip in for 1 second, and recolor after 1 minute. There's no training needed. It's a simple chairside process, just like blood pressure. Blood pressure, before we had the blood pressure gauge, people were dying of heart attacks, and physicians didn't know what their blood pressure was, didn't know how important it was to measure blood pressure and know who was susceptible. We have a blood sugar gauge. We had salivary screening during COVID. And this simple chairside process is rinse, spit, dip, and assess. And you can see at the bottom on the left, negative is basically a beige look. It's a beige color. Low is a light violet, and it goes to very high, sort of a very strong purple. So this is a fast, accurate chairside system. This is something that's available right now in Canada. It's called Perio Monitor. I'm in Canada, so that I have that available. It opens a wellness conversation. It strengthens communication. So patients will understand what you're doing for them. Because when you do bleeding on probing, they don't have any idea. They know that it's uncomfortable and you're poking a lot. You still will have to do bleeding on probing. But this is something that communicates what's going on in the oral cavity, and you can quantify it and show the patients quantifiable evidence. And it drives a practice growth through easy for me to say, case acceptance. It does not disrupt team workflow. It's easily integrated before prophy and scaling. Increases patient treatment acceptance for more frequent recalls, frequent monitoring of implant patients, and it generates value added income. It's a great way to communicate with your patient because they can see it and they can understand it. It can also detect inflammation before you see it clinically, and it monitors treatment progress objectively. So this is going to be available in the US probably within the next few months, and maybe I'm not sure exactly when, but it is available in Canada. It is going through regulatory. In the United States, it will be a wellness situation where it measures inflammation and shows you wellness, which we know is the oral systemic link. So again, simple to use, rinse, spit, dip, and assess. In Canada, it's called Perio Monitor. I don't know what it would be called in the US. So we have the means to measure the disease, and now we have a way of breaking the link between the oral and the systemic. So how can we break that easily in the office? When the diode laser first showed up in my office quite a few years ago, I got really excited and I wrote several articles on where have you been all my life? And because I couldn't believe the soft tissue diode laser, I call it my soft tissue handpiece, what it was able to do for me. It was surgical precision, bloodless surgery and post-surgery. Sterilizes the surgical site beautifully. It has the reaction of the patient is minimal swelling and scarring, coagulation, vaporization of the tissues, minimal or no suturing, decreased and no pain. So we can use it very easily to break the link between the bacteria and inflammation by laser-assisted periodontal therapy. Now, why can the diode laser help so much in laser-assisted periodontal therapy? Because of several factors. There are three major factors. The biostimulation, it is incredibly biostimulatory. It can decontaminate and remove bacterial effects. There's a great bacterial reduction. The sulcus is cleaned up and decontaminated after. And it can do a soft tissue curettage so that the tissue can attach itself easily back to the tooth with a soft tissue curettage. So what do I mean by biostimulation? Here we have cell biology. I don't know if you remember your cell biology. For me, it's been a long time, but I do remember some of my cell biology. With the mitochondria, you can see the mitochondria, the cell on the right side. So light photons are absorbed by the mitochondria of a cell. That will stimulate cellular energy. When you use your laser, you're stimulating cellular energy. You're doing what you have to do, whether you have to cut, whether you have to do curettage, whatever you're doing. Afterwards, the cell morphology and function is restored. But while you're doing what you're doing with the tissue, it's also stimulating a lot of secondary side effects. And these side effects are actually very beneficial. What are they? Okay, these are the clinical side effects, which are good side effects. They increase the lymphatic flow. That's why you have reduction in swelling. They stimulate endorphins, which is the body's own painkiller. So you have less pain. There's pain relief. It reduces the depolarization of C fibers. These are the fibers that carry pain impulses from the teeth. So that decreases the pain sensation. It also synthesizes collagen in the fibroblasts, and that's important in wound healing. There's a formation of capillaries, again, important in wound healing. There's a stimulation of osteoblasts and odontoblasts, and that builds bone and dentin. Decreases histamine, bradykinins, acetylcholine, and that decreases inflammation and pain. Whenever you do something with a laser, the first area, the area closest to the laser, will be vaporized. The area around there will have a carbonization. Then there's coagulation, denaturation, the photothermic effect, and the last is the photostimulatory effect. That's the biostimulation. All right, so that's biostimulation. The second thing is decontamination. The laser is bactericidal. It suppresses the very resistant, aggressive periopathogens that you can't get to with scaling and root planing, like Actinomycetum comitans and the other, and P. gingivalis. Has a long-lasting effect. So you decontaminate by firing the laser. It also helps with gingival curettage because it's well absorbed by melanin and hemoglobin. It specifically targets unhealthy gingiva that has melanin and hemoglobin. The fiber can penetrate the deep pockets, and there's the complete removal of pocket epithelium. And when it's used as an adjunct to scaling and root planing, there's decreased bleeding, inflammation, and pocket depth. It decreases tooth mobility, and the improvements are very stable. Patient comfort, we want our patients to be happy. This is what patients want. Patient comfort is enhanced post-operatively, during and post-operatively. So what exactly is the protocol? We measure the pocket depth. We do the scaling and root planing. So before we have a lot of bacteria, we have a lot of calculus. With the scaling and root planing, we no longer have the bacteria and calculus. We fire up the laser, and this is what it looks like with a laser curettage. We clean out the tissue tags, and when there's no more, there are no more tissue tags on the laser tip, we know we're done. So that's what the soft tissue laser does. It cleans it out, it decontaminates, and it biostimulates. So now we have a nice clean surface which has been biostimulated, decontaminated. 3 months post-op, we can measure. Now, the nice thing about the perio monitor as well is that it can show you results before you go back and check the pocket depth. So you should not be checking pocket depths before 3 months. But with the perio monitor, you're checking inflammation, and you can do that at any time because it's just a saliva test. So here we go. At this point, you've got nice, healthy gingiva that can attach itself back to the tooth. We go from here to here. So it's safe and effective. You have no alteration to the root surface, no thermal side effects, no adverse tissue events, decreased need for antibiotics. The Dental Laser wireless laser by Shofu is a great way of doing this. It's always ready. It's got disposable, self-bendable tips. You've got the laser shield included. It can do all soft tissue procedures. No setup time, no messy cords. It continues wave at 3 watts, pulsed is 5 watts. It's got lots of safety controls. It's very easy and super safe. It's a great way to do what your soft tissue handpiece needs to do, whether it's for laser assisted periodontal treatment or even things like an operculum that has to be removed. As I said, it's my soft tissue handpiece, just like you have a hard tissue handpiece that gets rid of materials that you don't want in the tooth and hard tissue. This is a soft tissue handpiece that can just excise and remove what you don't want in the soft tissue realm. So the benefits of laser treatment is biostimulation, bacterial reduction, hemostasis, better visibility, improved healing, enhanced comfort, which is what our patients want, and increase patient acceptance. And you can do a lot of different things quickly. So with a high-tech system, the patients like, and it can be very profitable as well, because these things in the old days were causing a lot of bleeding, and it would be you'd have to take a lot more time to do things, and that would cut into your bottom line. So we've got a paradigm shift here. We're doing, instead of a surgical model, we've got the medical model. We're doing biological dentistry. And this is what proactive win-win dentistry is, and what patients want and what we need. Less is more. It's less is what our patients want, because they want less. And we want less hassle, more predictable, more proactive, and more profitable dentistry. So thank you very much. And I'm happy to take questions. Flow Plus, I've used Flow Plus. I like Flow Plus X as well. They're both good. I stuck with Flow Plus because that's what I started with. So now, and the Fisher burr is a Fisherotomy burr by SS White. And that's the burr that I use. And it's great because it's the right size. And it also, it's tapered, so it doesn't cut a lot of dentin, because the dentin is what is sensitive, not the enamel. The enamel is wider, so you're removing more enamel, less dentin, so you're not cutting a lot of dentin, so it's less sensitive, and it's just perfect for the flowable material to go into. Am I at all concerned about using bioactive aluminum in the mouth? I don't think it is a problem. It's not a large amount. I don't think a bioactive aluminum will be a major problem. It's got a lot of benefits, not too many problems. Oh, somebody said that they've been using Beautiful for years and have not realized they had such great properties. And they said, no wonder they work so well in class 5s and worn dentition. Okay, well, now you know that not only is, and as I said before, people will be happy to use a material because it's got great handling properties and great physical properties, but they're not always aware of the other properties. Because dentists obviously we want something that's easy to use because that's what we need. That's what we want. So the handling properties are great. The physical properties are great, but they also have these bioactive material properties as well. And the matrix for the posterior, I would use a metal matrix, and just whatever metal matrix you have, you can use there. The stored material cannot be placed in a wet field. You don't want a wet field because it's a composite. It's a composite resin. Notice I'm saying composite and composite because I am Canadian and I do a lot of lectures in the United States, so I go back and forth. In Canada, we say composite. In the United States, you say composite. And there are a full range of dry armor products. You've got the Beautiful Flow Plus and Flow Plus X, which were mentioned. but you also have the Beautiful 2, which is a hybrid material when you need more structure. So that would be the best when you need more structure and something a little bit that needs a little bit more substance. I would go and more of the tooth is taken away. You would use the Beautiful 2, which is a hybrid material. But any other places where there, you just have a small area, just flow in the Beautiful Flow Plus. Something with charging for the additional laser treatment. Yes, I would charge for and it depends on the places, the state that you're in. But you definitely should charge for the laser treatment. It is, I mean, you're doing a service to the patient. Absolutely. The question was how the length of the gymer, a regular size filling, as long as or longer than most of composite resins. There have been studies for, as I said, 13 years. There was a 13-year study done many years ago, and they were fine for 13 years. Depends on the operator, of course. If you're doing whatever you're doing with your regular composite resins, you're doing a good job. But the gymer will last as long or longer, especially because it's got the bioactive effects. You're less likely to have redecay, and it probably will last you longer. Can Flow Plus replace all packable resins? I think, as I said, I use a lot of Flow Plus. Plackable resins seem to be what's going on now. I am still using Flow Plus. I think I use it. I'm happier with it. And I do use it in incremental ways. And I'd rather save, I don't think you save that much time if you do there's a lot of stuff on lights and how well you're actually curing when you're using a packable and you're curing 4 millimeters. I don't like to do that. I'd like to do it more in layers. The bonding agent, I use the Beauty Bond. I think it's a better material to use with the Flow Plus, but you can use, and that's the best because it also has great properties. Question about the Beauty Flow 03. You don't have to place a liner if you're using the Flow 03. And I think that is all the questions that we have.